Welcome to Echocardiography lecture series. Not all echocardiography studies are the same. You should only accept and perform high quality study. In this lecture, you will learn how to perform a high quality transthoracic echocardiography study. So let's begin. This is transthoracic echocardiography part 2, where we're going to discuss the image acquisition sequence as well as some basic measurements. Measurement details are discussed in later videos. The first view that is acquired in transthoracic echocardiography is the parasternal long axis view. However, it is acquired at a high depth in order to see if there is any mass effusion, etc. in this area here, where usually if there is a pleural effusion we can see it here. Then the depth is decreased, so we can see the heart and nothing but the heart. So we will have a good temporal resolution as well as spatial resolution. Freeze at the end diastolic frame, the frame that has the thinnest LV walls and largest LV cavity, and measure the following. Measure the septum here, and we call it the interventricular septum diameter in diastole, IVSD. Then measure this cavity, the left ventricular internal diameter in diastole, the LVID, and measure the LV posterior wall in diastole, LV posterior wall in diastole. Measurements should be obtained at the level of the mitral leaflet tips. At this level. Not here, not here. However, if you have a sigmoid septum, you should pass it and measure after the sigmoid septum. Do not measure the sigmoid part of the septum. And we will see this in later videos. As a rule, tissue measurement, let's assume this is a tissue. Here, this is another tissue. This is, let's say it's a LV wall, and this is another LV wall. So any tissue, we measure it from outer border to outer border, outer border to outer border. In cavity, in general, cavities are measured from inner border to inner border, like this. So, in that case, this piece, this wall measurement will belong to the tissue, not to the cavity. This wall here will belong to the tissue, not to the cavity. However, there are few exceptions that we're going to see in the coming slides. Then freeze the image at the end systolic frame, the frame that has the smallest LV cavity. And what you need to measure here actually is this, the LV internal dimension in systole only. Proceed then with M mode acquisition. Acquire M mode in 3 levels. The aortic valve level, so here you will see the aortic cusp coaptation, and you align the beam at the coaptation line. Then do the same thing to the mitral valve. Align the beam to the coaptation line of the mitral valve and acquire M mode. Then also align the cursor of the beam at the LV mid-wall here, mid-wall of the LV, and acquire M mode as such. Next, put colored Doppler sector on the interventricular septum, and this is to check for ventricular septal defect in the anteroseptal area here. And note that this sector is covering only the interventricular septum area. This is not to lose temporal resolution. Also note that the color scale or the Nyquist limit here is adequate. It means if you are expecting a high velocity flow, let's say arterial flow, ventricular flow, VSD flow, you need to make sure that the velocity, the Nyquist limit velocity, is at least 55 centimeter per second up to 70 centimeter per second. However, if you're expecting a low velocity flow like atrial flow, venous flow, this has to be decreased. So let's assume that the velocity is at 30 centimeter per second, which is a low velocity flow. That means in the current scale, it will be shown around here, which has a little bit of color only, and you might miss it because the shade here is almost black. But if you decrease this color scale and you make 30 is here, so you can see it very clear. Next, decrease depth, then zoom at the LVOT and aortic valve and acquire this video clip. You need to remember that zoom alone is not enough. First, you need to decrease the depth. Decrease depth. The reason why you decrease depth is you improve temporal resolution. You improve the frame rate. Then you do your zooming if needed. Next, measure and acquire the image of your measurement of LVOT. So, first of all, we need to acquire it at mid of systole, where the aortic leaflet are widely open. And then we have to check where is the annulus. The annulus is the insertion point of the leaflet. So this is the insertion here and the insertion there. So insertion to insertion is the aortic valve annulus. And we have to take our measurement inner to inner because it's a cavity, and it has to be around 5 to 10 millimeter away from the annulus. Then measure and acquire your measurement, the aorta at end of diastole. So usually 2 levels are sufficient. The level of the coronary sinuses. So this is the sinuses. This is a sinus. This bulge here is another sinus. So we measure at the level of the sinuses in a perpendicular manner to the long axis of the aorta. And the measurement here has to be leading edge to leading edge. Leading edge to leading edge, or let me show you what I mean by leading to leading, or outer to inner. This is outer to inner. This is how we measure it, because this is how we have our reference values. This is how it was originally measured, and it correlates very well with the measurement of CT scan. Again, anything beyond the valve, so this is the valve, this is the aortic valve. Any measurement distal to aortic valve, whether being at the level of sinuses, ascending aorta, it has to be leading edge to leading edge, or outer to inner. From outside of the wall to the inside of the wall. So now in the same view, before you leave this view, just put a color sector for color Doppler here. As a rule, before you go to any other view, finish the measurement, the color Doppler, whatever Doppler you need to acquire, finish it before you go to the next view, and instead of going back and forth to the same view. Then zoom at the left atrium and acquire your measurement. This measurement is done as follows. Leading edge to leading edge. I mean outer to inner, and it is at the level of the sinuses. So this is the aortic sinus here. So we take it at the level of the sinus and in a way perpendicular to the LA long axis. So this is the LA long axis, the left atrial long axis. So we measure it in a perpendicular way. We don't measure it like this or like this. We do our best to take it in the level of the sinus, leading edge to leading edge, and perpendicular to the long axis of the left atrium. Then put your color sector at the mitral valve. And of course, because here we are checking mainly for mitral regurgitation as well as mitral stenosis, but mainly is mitral regurgitation. So this is why we have to include the whole of left atrium. So putting the sector only here is not adequate. So we need to see the extent of the mitral regurgitation. So this is why we need to include the whole of left atrium here. Next view is the RV inflow in 2D. And again with color. And because we expect a high velocity in tricuspid regurgitation as well as mitral regurgitation, we need to use adequate Nyquist limit. Next, align your spectral Doppler cursor to the tricuspid regurgitant flow and acquire CW or continuous wave Doppler of the tricuspid regurgitation. As you will see in the coming slides, we will acquire CW of TR in many views because you never know when you will see the best regurgitant flow. This is not mandatory, but it is nice also to put a sample volume just above the tricuspid valve to check tricuspid valve inflow. This is used for diastolic evaluation or evaluation of diastolic function of the right ventricle. Then proceed to the RV outflow image in 2D. And apply color Doppler. Also note the regurgitation here where you're going to align your spectral Doppler cursor. Then acquire a continuous wave of this regurgitation here as well as the outflow here. Then acquire a pulse wave Doppler proximal to the valve. So if this is the valve here, the pulmonic valve, so you need to align or to adjust your sample volume proximal to the valve here. Then proceed to the parasternal short axis, starting with the basal level, which is aortic level, and acquire a video clip. Then decrease depth and zoom and acquire the aortic valve So in this view, you can easily determine if this is a tri-leaflet aortic valve or bicuspid aortic valve, etc. Then put a color Doppler sector on the aortic valve and around the aortic valve also to check not only for aortic regurg but also for a VSD. And this is a very good view for perimembranous VSD and supracrustal VSD. Then we little bit angulate to bring the pulmonic valve into view and put the color sector there. And similarly to the previous pulmonic valve Doppler, we will acquire a CW and then PW. And this is a pulse wave Doppler of the pulmonic valve. Angulate to bring the tricuspid valve into view and put a color Doppler there. With the help of color Doppler, adjust your cursor and align it with a tricuspid regurgitation flow and acquire a continuous wave Doppler. Then zoom at the interatrial septum and put a color Doppler here. Note that we are using here a low Nyquist limit or a color scale. Here we are using a 35 centimeter per second because this is an interatrial flow and it is a low velocity flow. Then we'll angulate until we get the parasternal short axis view at the mitral level. You need to see clearly the anterior mitral leaflet and posterior mitral leaflet here. Again, a color Doppler will be put here, and you should also include the interventricular septum looking for VSD. Then we will acquire parasternal short axis at the mid-level here, where we can see clearly the papillary muscles, the posteromedial and the anterolateral papillary muscles. A color Doppler is then put here, and again you should include the interventricular septum. Then we will acquire parasternal short axis at the apical level. Again, color Doppler here is put around the apex and is including the interventricular septum. Then we'll proceed to the apical views. The first view is apical fourth chamber and it will be taken at a high depth. Again, looking for masses and effusion here around or beyond the heart. Then we will acquire a 2D video clip of the fourth chamber by decreasing the depth and acquiring the whole fourth chamber here. We'll decrease the depth. It is not zooming. Again, it is decreasing the depth. we will include the mitral valve, but not the full of LA. So we need the highest temporal and spatial resolution here. So we need the LV only, and this is being used for measurement of LV function as well as strain imaging. Color Doppler sector is then adjusted on the mitral valve, including the left atrium here and part of the inflow here. And if you're suspecting mitral stenosis, you might also need to include the LV here or take two separate color Dopplers. Continuous wave Doppler is then acquired along the mitral valve, mitral inflow, and mitral regurgitation. Then the sample volume of the pulse wave Doppler should be adjusted here at the mitral leaflet tips. So this is the mitral leaflet tips here, and your sample volume should be adjusted above the mitral leaflet tips and acquire a pulse wave Doppler. Another pulse wave Doppler should be acquired, however, this is at the level of the annulus. So this is the mitral leaflet here, and we said the insertion point to insertion point is the annulus. So this is the annulus of the mitral valve, and your sample volume should be adjusted here. And this has a lot of uses, and we will see those uses in the coming videos. One of them is measuring the A wave duration, as you can see here. Then looking for pulmonary vein, and this is the site of the right upper pulmonary vein. You put color Doppler here, try to find the pulmonary venous flow here, and then you will adjust your sample volume here. There is one mistake here because this is pulmonary vein, and you need to see that the Nyquist limit here used is for high velocity flow, and it should be between 35 to 40 centimeter per second, not 62. Next, you adjust your sample volume around 5 to 10 millimeter deep within the pulmonary vein, the right upper pulmonary vein, and acquire the pulmonary venous flow, as you can see here. Next, we'll acquire a tissue Doppler imaging of both RV and LV. Then we will sample the velocity at the LV annular level, the lateral annulus here of the mitral valve, and then the septal velocity here. So it should be annular level of LV, one is lateral, and the other one is septal, as we will see in the coming image. And then also we can measure the velocity here. And this is the acquisition of the septal level here, or site. The systolic velocity has to be measured of the RV free wall here, so you adjust your sample volume if this is the RV wall, so you put your sample volume at the tricuspid annular level here, and you measure this systolic velocity of the free wall, and we call it S prime. Then we will proceed to the RV focused view. In RV focused view, if you note, this is the LV apex, and it is in the center of the sector pointing toward the probe. So this is the probe here, and this is the LV apex. However, we will angulate the probe anteriorly or posteriorly to get the maximal size of the RV and RA, and this is called the RV focused view. Also here in this view, we will measure the RV internal diameter and end of diastole. Let me just stop the video here. So we measure it in end of diastole, the largest RV size, and we measure it here, basal diameter. We can also measure another measurement at mid-level. However, this one here is mandatory. Then we measure something called TAPSE of the RV. We align this M mode cursor here to pass through the lateral wall and lateral annulus of the RV. So if this is the RV here and this is the LV here, we make sure that the M mode will pass here. And this will be further explained in the coming videos. Then we check for tricuspid regurgitation again. Here we can use RV modified view as well as RV focused view. Any view that will give us the best tricuspid regurgitant jet, we will use it. And the RV modified view, if we're using the modified, where the LV is not in the middle of the sector and not pointing direct toward the probe, we use it only for tricuspid regurgitation and measurement of this flow, just to align it with our Doppler beam. And then we acquire a continuous wave Doppler of the tricuspid regurgitation. In RV focus view, again, I have to emphasize this point where the LV is in the center, pointing direct toward the probe. We move the probe, we angulate a little bit anterior or posterior just to get the maximum cavity size of the right atrium. And we store this to measure the right atrial volume. Then we zoom at the interatrial septum and we put color Doppler accordingly. This is a color Doppler of the interatrial septum, and as you can see, the Nyquist limit here was decreased to 44. Ideally, it has to be less than 40 centimeters per second. If you have the capability of 3D, before you leave the apical fourth chamber, just acquire the 3D image of the LV. From the apical fourth chamber and a little bit of anterior angulation, we will record the apical 5-chamber view in 2D. Then put your color sector here in the LVOT and aortic valve. The color flow should guide your cursor of Doppler. So then you align your cursor of Doppler here, parallel with the color, and acquire a continuous wave Doppler of aortic valve. Then acquire a pulse wave Doppler of the LVOT. If you remember, in the parasternal long axis, this is the LVOT here, this is the aortic valve, and this is the mitral valve here. So we measure it around 5 to 10 millimeter away from the aortic annulus, somewhere here. So now we have to do the same thing, and we have to measure the LVOT flow 5 to 10 millimeter away from the annulus here. Ideally, it should be exactly. So if you used 5 millimeter in the parasternal long axis, now you have to use 5 millimeter. So where you measure the dimension, you should measure the Doppler. Then acquire apical two-chamber view, including the left atrium. And then put a color Doppler on the mitral valve, also including the whole of left atrium in the color sector. Then decrease the depth to include the LV and only small part of the LA. Do not zoom, only decrease the depth. So we will have the highest temporal resolution. Proceed to apical 3-chamber and acquire a 2D video of the apical 3-chamber view. Similar to previous apical views, just decrease the depth to include only part of LA and the whole of LV. Put a chiral Doppler on the mitral valve here, including the left atrium. And sometimes if you see a good mitral regurgitation here with good alignment, you can take a continuous wave Doppler of the mitral regurgitation. Now, similar to apical 5-chamber, we will adjust our color sector to include the LVOT and aortic valve. And guided by the color flow, we will obtain a continuous wave Doppler of the aortic valve. And then we measure also the LVOT by pulse wave Doppler. The reason why we measure it in apical 5 and apical 3, that again, you never know where is the best flow you can get. Shifting to the subcostal window. The first video which is acquired here is the subcostal 4-chamber view. Because this view will have the best alignment of the interatrial septum with the color Doppler as well as with a spectral Doppler like this. So this is the right atrium and this is the left atrium and your beam is here. And if there is an interatrial defect, your flow will be either going up or down between the two atria in a way that is parallel with the ultrasound beam. So this is the best view to check for interatrial septal defect. And as you can see here, the color Nyquist limit was decreased below 40 because this is an interatrial flow and we are expecting a low velocity here. Again, we put our color Doppler here at the tricuspid valve and include the right atrium, just to trace the tricuspid regurgitation jet. And as you can see here that the Nyquist limit was adjusted for tricuspid regurgitation. And then a continuous wave Doppler was taken from the tricuspid valve. Those are subcostal short axis views at different levels, and those are optional views to be taken. The IVC here is mandatory view, and you need to record something between 10 to 15 cardiac cycles. You need to see the collapsibility of the IVC here, and also you ask the patient to sniff, and ideally you should uh, annotate sniffing in the image. Then put a color Doppler sector on the hepatic vein. So this is the hepatic vein, and because it's a venous flow, the Nyquist limit was adjusted here. Then the sample volume of pulse wave Doppler was put within the hepatic vein, and the flow was sampled as seen here. After that, move to the descending aorta and acquire it in 2D. A single beat is enough. Acquire a color Doppler of the descending aorta. Also, sample this flow of the descending aorta by pulse wave Doppler. Now moving to the suprasternal window, acquire the aorta, as you can see here, descending and the arch and the descending aorta, and try to include the arch vessels as much as you can. And you need to have also a reasonable depth to include the right pulmonary artery, as well as if there is any structure here, like the left atria. Then put your color sector and include the ascending aorta, the arch, and the descending aorta. Most importantly here is the descending aorta. Again, guided by color, adjust your Doppler cursor to pass through the descending aorta and acquire a continuous wave Doppler, which has to be followed by a pulse wave Doppler at the same position of the descending aorta. In order to minimize the scanning time and the discomfort of the patient, sometimes we can defer measurements or some of the measurements to be done after you finish the study, and we call them offline measurements. I will go into great details of these measurements in coming videos, but for now this is apical for chamber, and we trace the LV here in diastole and in systole to get the volumes and the ejection fraction. We repeat the same thing in apical two-chamber view. The left atrial volume has to be measured in apical four-chamber and apical two-chamber view. And in RV focus view, we have also to measure the RA volume by tracing the right atrium. If you acquire a 3D volume, now it is time also to measure the volumes using 3D offline measurements. This is a very important part of this presentation. Image optimization. First, how many cycles you should take. If there is no arrhythmia, no tachycardia, a single beat acquisition is enough. If there is any arrhythmia or tachycardia, 3 to 5 beats should be acquired. The gain knob on the machine will determine how much power you will give to the signal or you will take from the signal. In this image, because there is a part of the septum where you don't see it, so it is undergained. In this image, you see a lot of noise here. This all white things here. You don't see a black cavity like here. So this one here is overgained. You need to see a black cavity, but without losing any other structure. And I will show you an appropriate gain like in this image. This image or this video has an appropriate gain where you have a black cavity without losing any structure. Gain does not only apply to 2D image, it also applies to Doppler, being color Doppler or spectral Doppler. In this image here, it has a high gain. As you can see, the background is white or gray. It has to be black. So this one is overgained, and this is how an appropriate gain should look like. Compression is another parameter that can be used to optimize the image. Here, in image number 1, compression is decreased, so you have less number of shades that represent the ultrasound signal. Compare it to number 2 here, where you have adequate compression, where you have enough number of shades that represent the ultrasound signal. So in number 2, you have a better tissue characterization. However, in number 1, you will have more of black and white, and it can be used like in contrast echocardiography, where you need to see the endocardial border or the cavity only. Rejection or filter is frequently forgotten knob. Rejection, you will reject or filter out the high amplitude but low velocity signal that comes from tissue. So this is too high rejection, where you can see the baseline here, the low velocity are filtered out, so you don't see exactly this flow starting from where exactly. Does it start from here or from here or from here? You don't know exactly. So you should adjust it to be an appropriate filter or rejection, where you can see this flow goes all the way to the baseline without having too much white in the center like this in the baseline, around the baseline. You don't need something like this, otherwise it will be too low of a rejection. As explained in physics talk, as beam propagates, it will divert and lose lateral resolution. This is why we should use focus. And the area of focus can be presented by a symbol in the image, like here and here. So if your area of interest is the apex, looking for any apical mass, you should move your focus point to be aligned with the apex. So again, changing the focus, moving the focus to the area of interest. Another part of image optimization is always use the appropriate depth. So sometimes you need a high depth, like in this image, but you need also to take an appropriate depth and decrease depth. So make sure that you always use the appropriate depth that you need. The standard color is gray. However, in difficult images, changing the color mapping can aid visualization. As explained many times, that spectral Doppler should be guided by color Doppler. So you need to visualize exactly where is your jet of interest and then align your Doppler cursor along that jet. Part of Doppler optimization is angle alignment. So try as much as you can to align your Doppler angle here, or beam, the green one here, with the jet direction. So this is your jet, this is the direction of the jet, so the angle is here. The angle between the jet and the Doppler beam is the angle of incidence, and anything less than 20 you can omit it and skip it. The scale also is very important. So in this image here, image number 1, you can see there is an adequate scale of velocities. So you can see the jet, this jet here is very well represented, but this one here is very small, and this will increase the margin of error during measurement. So this one here, you should adjust the scale as much as possible to have a larger jet, so that will decrease the margin of error during measurement. Similar to velocity scale, the sweep speed should be adjusted according to the need. Like in this case here, it's a mitral stenosis, where you need to measure this deceleration slope. And in order to decrease the margin of error during measurement, you have to increase that horizontal sweep speed. On the other hand, if you need to include more beats, like in this case, where there's some pericardial effusion, you want to check for tamponade, you need to see the respiratory variation, so you need to include more beats. So you will decrease the sweep velocity and you will have more numbers of beats are presented here. And you can see it going with this respiratometer here. Again, as mentioned earlier, that the color Doppler sector should be adjusted to include the region of interest exclusively, no more and no less. A bigger color sector will reduce the temporal resolution significantly, while a smaller color sector will not answer the clinical question. This one here is adequate. So if you are looking for mitral regurgitation, you will see the mitral regurgitation and the extension of this mitral regurgitation into the left atrium. The reporting of transthoracic echocardiography and the structure of the report is actually beyond the scope of this talk. However, few things has to be present in appropriate transthoracic report. We can divide them into demographics that include the date of the study, name of the facility, etc. You can go through them and you can find them in many guidelines. And then also quantitative data and numbers, and then text itself, as well as the summary of the report. Thank you for watching. The next lecture will be about left-sided chamber quantifications.